not a discussion. Thank you. Thank you. And now it's a great pleasure for me to welcome Aisha Sethi. Please. Aisha Sethi is the director of the Yale Dermatology Global Health Program. I know Aisha since a very long time during our co-work, like we said, like ancients from the RTTC in Moshi in Tanzania. She is an outstanding expert in the field of tropical dermatosis. She is just coming straight from Pakistan, her home country, which is threatened by so intensive floodings and causes uncountable human sufferings. And it's really also a real tragedy, and it favors also in further consequence, of course, the outbreak of dengue fever. And so you will tell us that. Aisha,
thank you, Rosemary. Thank you so much. How do I advance the slides? Okay. Okay, great. I'm not very great at technology, so that's my conflict of interest. Thank you so much. I'm seeing so many mentors here and collaborators and dear friends that I met through this interest in tropical dermatology. I was born in the United States, but I was raised in Pakistan, so I'm a bit of a gypsy doctor, but I practice in the US. So I'll just get to it because I know we're running somewhat of time, and I'm going to talk about dengue fever today. So I don't have any conflicts of interest. How does tropical medicine tie into global health? And how does tropical dermatology tie into global health? And I put Mount Kilimanjaro in the back there because I think that was sort of one of the starts of my journey of meeting a lot of people here and collaborating with in dermatology. So neglected tropical diseases and skin disease have had a centuries-old connection. In America, it's kind of divided that more infectious disease doctors have taken over some of the infectious diseases. And in Europe, still, we call it dermatovenereology. So that's one of the things kind of to note that that shift happened in the United States. One of my mentors once said that this is the most dangerous animal in tropical medicine, the mosquito. And we all know the various species of it. And when we're doing training, we have to memorize what kind of species transmit what kind of viruses or parasites. So this is one of the fathers of tropical medicine, James Lind. He was a naval physician. And I love this quote that the great mortality in the hot climates should draw the attention of commercial nations of Europe towards preserving the health of their countrymen whose business carries them beyond seas. This is a centuries-old quote, and I think it's still relevant to this day when global travel and what we saw with COVID has become more relevant. So NTDs, over 2 billion people are affected, and if you just run your eyes over this list, I think I'm going the wrong way. Oh, here we go. So if you just run your eyes over this list of the NTDs, you'll see dengue is right there. And I marked in blue, including dengue, that most of the neglected tropical diseases primarily actually have a dermatologic manifestation. However, conversely, few dermatologists are trained in recognizing a lot of the signs and symptoms of this condition. And if you look at the trainees in the US or even Europe in the major urban areas, they'll be like, oh my God, I saw a case of this. Oh my God, I saw a case of this. You know, it's kind of something we don't get exposed to, but more and more in the last 2 decades, we've seen this more in travelers, in people like the military who were deployed at least for that time in Iraq, Afghanistan, like Leishmania. So now we're going to travel. So this is a case of a 65-year-old businessman from Pakistan, 2-day history of high-grade fever, severe myalgias, and arthralgias. My body aches like someone beat me up. This patient went to 2 physicians, and as it happens in Pakistan, you get diagnosed with typhoid, you get treated for malaria, and 2 different doctors gave medicine for typhoid and malaria, and then nothing came back on the cultures. And this is a case from 15 years ago. The blood count revealed a slightly decreased platelet count. So we know what the lecture topic is. So this was dengue. And this patient had a rash, a petechial rash on the legs. So the third doctor finally said, let me check dengue serology. And it was dengue. And this was a period of a great outbreak in South Asia more than a decade ago. This is a picture of my father, and he was in the ICU, and his platelet count fell down to 10. And he did recover, but the platelet machines were broken. There were only 2 functional ones in the city because it was a big outbreak, and they were not prepared for that at that time. It was the first major outbreak of dengue in South Asia. So dengue is a very historical disease. It's a virus, and it is from the phrase cramp-like seizure caused by an evil spirit, because it's also called breakbone fever, and the body aches and myalgias are really severe in dengue fever. So in the field, they don't even do serology. It's like a field diagnosis and outbreaks. Pretty much prevalent throughout most of the tropical world, as we know, as this crowd knows. And the prevalence was in the United States, about 100 to 200 cases used to be reported to the CDC about a decade ago. And most of these were in people who had traveled abroad. And if you look to prior to 1981, this map of Central and South America, and then you look 1981 to 2003, suddenly you're seeing it's all red with dengue outbreaks. 50 million people worldwide each year are affected by dengue. And this is something that climate change experts were warning 2 decades ago. I've been giving a talk on dengue now for, I think, 18 years, that were warning that it's going to increase, the outbreaks will increase. But of course, we have political comedies in every country, people who believe in climate change and who don't. The virus has 4 serotypes. It's by the Aedes, transmitted by the Aedes mosquito. So it's also called the tiger tail mosquito. And the classic clinical symptoms of dengue are fever, petechial rash, muscle and joint pains. They use field criteria, but most of the time I'll tell you in the field, it's like a field diagnosis. People don't even do blood work to see the thrombocytopenia in outbreaks. Hemorrhagic fever is when you get concerned. So people who've grown up, for example, like myself in South Asia, we probably had fever. If we did dengue serology, we probably have antibodies. It's when you get re-exposed is when you're likely to get the hemorrhagic form, and you have a higher sort of immunologic response. And that's when things get tricky. And if you want, you can do serology in some countries. And then what's in the differential diagnosis? So now we know of the other viral illnesses, but given sort of the fever, the body aches, chikungunya, now we know Zika, these are all sort of in the differential diagnosis of dengue fever. And if we're in the West, also we need to add some of the other illnesses, and depending on where you are, sandfly fever also, if you're in the Mediterranean. There is still no specific treatment for dengue, as in a specific targeted antiviral. We counsel patients to drink lots of fluids. Children are at higher risk of dengue shock syndrome, not to take aspirin because of the thrombocytopenia. And so it's supportive treatment. One of my dear mentor said it's the most important mosquito-borne viral disease affecting humans, even maybe surpassing malaria, because we do have treatment for malaria, right? But we don't have specific treatment for dengue. So this, I want to show this crowd, this slide from 2005 or 2006 when I gave my first talk of dengue. And it shows that in the CDC collected data, and if you're seeing in most of the US states, each case of dengue was in people who had traveled abroad, okay? And in Puerto Rico, it was somewhat endemic at that time. And then this was the 2012 outbreak that I showed you, the case of when my dad had dengue. And then suddenly dengue started coming in 2011, moving forward from 2005 to 2011 in the US, and it was being reported in parts of Florida. So then more in the news. And then people were spraying stagnant water in parts of Florida. And now we have dengue reported as being in the Keys of Florida in people who have not traveled outside of the United States. So now it's there. So more in the news. Another kind of key fact travel clinics usually counsel patients about, this is a day biting mosquito. For example, the Anopheles is like a night biting mosquito. People associate mosquitoes with the evening time. So that's a really good sort of counseling tip for patients that the Aedes is a day biting mosquito. There's some posters from global prevention campaigns. And then there was a company that was looking at genetically altered mosquitoes to curb dengue fever. And they released some of these mosquitoes actually before the Olympics in Brazil to make sure that they were able to host the Olympics, so that these mosquitoes actually are rendered, they die quickly. And Oxitec was the company that produced them. But there was a case to produce and release these mosquitoes in Florida, but there were some people blocking that politically. So this was pretty cool how sometimes devastation leads to innovation, I think. So some locals created an app in Pakistan that wherever they saw stagnant water or a dengue outbreak, they would geospot that location. So public health officials would know where to come and spray the area. So that was pretty cool that some youngsters did that. I just put this question in there. Not as a test, but the right answer is Lassa fever. That Aedes mosquito is a vector for all the rest of the diseases. This was a patient that came in, a healthcare worker during Zika. So I just wanted to show you there's a morbilliform rash with Zika usually. Somewhat can be petechial, but Zika also has this lateral conjunctivitis sometimes. And these are posters. Again, public health is so important, as we saw with COVID. So this is a poster the CDC had created when Zika was having a surge a few years ago. This is my daughter in Pakistan, 1-year-old with a crazy tropical derm mother. So I bought this mosquito net that opens up like this, and I used to spray it before she was allowed to play in it. So I have her picture, she's 8. She knows she's in my presentation. And the good news is there's a vaccine now. So it's a tetravalent vaccine, Dengvaxia, and it was produced by, and I again have no conflicts of interest, Sanofi Pasteur. However, it's only available in 11 countries, and it was supposed to be rolled out this year. It's 3 doses, and it's approved for children from ages 9 to 16, and they should have had a previous dengue infection, because they saw a very bad immunologic response. So it protects against severe dengue and hospitalization. So the good news is there is a vaccine. However, it's not available in the countries that most need it yet. So I'll just talk about societal disruption and dengue a bit. So a lot of storms, as we know, have been in the news, or hurricanes, since the past 15 years. So I'm going to talk about 2010, when Pakistan had the first major bout of flooding. And you can see over here, all the red areas were all flooded. And Pakistan has 5 rivers that flow through the country from the north of the Himalayas all the way down to the Indian Ocean. These are pictures from the 2010 flooding. 20 million people were affected. And you can imagine a lot of infrastructure was destroyed. This was 12 years ago. The army got involved. So in dengue, in a lot of countries, in South America also, military gets deployed, because climate refugees, displacement, robbery, and crime can go up. Plus the military is very, very efficient in a lot of countries, setting up tents, distribution of food in a very disciplined way. So the army has been deployed right now in Pakistan also. So these are the hazards with flood water. You can see the hygiene conditions. And dengue is one of the top things that is a risk, because it's endemic in Pakistan. And with the stagnant flood water, you can imagine waterborne diseases are going to be in the top conditions seen. So the top medical issues at that time were diarrhea, skin infections, and URIs. This is in 2010. And you can see over here, Khyber Pakhtunkhwa is the north province that's close to Afghanistan. And skin diseases, you can see 40,000 cases were recorded within a 3-month period, just in one province. A bunch of dermatologists set up teledermatology centers in the 2010 floods and mobile skin clinics. I worked in those clinics in the 2010 floods. Language is, of course, positive. However, a lot of women saw a female doctor and they were asking me gynecologic questions and everything, which of course I'm not able to do. But these were very good clinics that were set up. And so I had experience working there. And this was our dermatology pharmacy. It's a very charitable nation. There's Ivermectin available, which I was talking to Valeska about scabies. Ivermectin is available in Pakistan. I've heard it's not available in a lot of countries. This is me trying to create a queue and I failed miserably. So you can see I failed miserably. These are some of the conditions we saw. So lots of tinea, lots of impetigo, cellulitis, lots and lots of scabies, impetigo. Moving forward to the year 2021, people got busy with COVID. They forgot about dengue. Then there was a big surge of dengue on top of COVID. And the poor Pakistanis, they have a great sense of humor. They said, we can't go inside because of COVID. We can't go outside because of dengue. Where should we go? You know, so a great sense of humor. So 2022, disastrous monsoon rain, more than 400% recorded rainfall in Pakistan, plus a glacier burst in the north of Pakistan in the Himalayas. So it was like the perfect storm. Because of warming, the glaciers melted and a big glacier burst. So it was catastrophic in the last 6 weeks. So 2022, half of the country at this point is underwater. And the deep red areas signify where everything's pretty much been destroyed. That's 1/3 of the country. You can see this is a picture from aerial view of Sindh. You see all that water, and you can think, all of you as physicians, what's going to happen next. So waterborne diseases. Again, skin disease is in the top 3 conditions. And right now I'm creating a small handbook that I showed to Valeska that I've been asked to, that can be dispersed to physicians on the ground. And they're not even physicians on the grounds. This is medical workers on the ground who just need to know symptom, diagnosis, treatment, and that's it. So this is standing water from this year. You can see. And as expected, just in the last 10 days, there's been seeing a spike in dengue cases yet again. And this is usually the time when dengue starts to spike anyways, because it's the end of the monsoon season in Pakistan and India and Bangladesh. And this is my daughter picking her nose. I just wanted to put her there with tropical flowers on her head in Pakistan, just to lighten the topic a bit. And thank you so much. And I love this proverb because I really believe in it. And I hope to make some new collaborations here with some new friends. Thank you so much.
Thank you very much, Aisha. It was wonderful. We might do questions at the end. And I'd just like to point out that we've actually got a member of the Climate Change Committee from the International Society in the audience. So Johannes David, it's very welcome. Thank you for coming along. And I know you've been really critical on writing the position of ISD. And we look forward to the discussion a little bit later on. So we've got the relevant experts for that. So we're really pleased next to call on Charlotte Bernagore to come up. Charlotte is a scabomaniac along with me, and so has been absolutely instrumental in taking forward the International Alliance for the Control of Scabies. In a previous life, she was a researcher at Créteil University in Paris and did a PhD on scabies and a pig model on scabies. But she has now moved and she's gone into big pharma, where we hope she will send money out of big pharma into global health dermatology. And she's currently a clinical research director for immunology and inflammation at Sanofi. But we're really excited to hear her talking about her real love and passion, scabies. So thank you.
Yeah. Thank you, Claire, for the very nice introduction. And it's true. It's, I discovered the mites and then now it's just, it's becoming a real passion. And I'm still very passionate about the tiny, tiny mites, all of the mites, but particularly scabies, where I worked a lot on it. Yeah, working. So as Claire said, now I work for Sanofi for the past year, and I was also an unpaid consultant for medicine development for Global Health, which is actually trying to develop the Mucicutaneous for scabies. I will talk about it a bit later. So scabies, it's an old disease, that's for sure. It was known for many, many years. It's written in the Bible from Greeks, Romans. It was also illustrated in the 17th century. It was for a long time overlooked, not really studied. There were quite some publications around World War II, especially by Kenneth Mellanby, which is a British researcher who worked a lot on scabies transmission, which actually made some studies that may not be feasible now, but he actually understood a lot about the transmission of scabies. And then for sure, the discovery of permethrin and then ivermectin were really important milestone. And finally, it got some attention. I would say that for the past maybe now 10 years, there is a lot of great research that has been made on scabies. Of course, the Nobel Prize for ivermectin and the overall family of the macrocyclic lactone is really a step forward. And of course, the IX, which we already talked about it, which is a group of experts working on scabies. There is now various research groups around the world. Of course, all the new technologies, multisomics, are really helping to try to understand the pathology of this disease. There is a lot ongoing about mass drug administration. There is a rising numbers of publications with very high and huge impact and in great journals. And it's great also that gets some attention there. And when we look on Google Trends, it's just rising. So it's from all over the world. So the mite cycle is actually, scabies is one, it has several varieties depending on the host that they affect. It can be the humans, it can be dogs, or it can be other species. It's an obligatory parasite, completely dependent on its host for its survival. There is no intermediate host and non-environmental reservoir, so should be easy to target and to eradicate, but it's not, at least not for the moment. And the cycle is around 9 to 14 days. Scabies prevalence, as you can see here, even it's 2017 data published in the Lancet Infectious Disease, which is actually a great work putting out together all the data to kind of see and try to map scabies. As you can see, it's really all over the world. It's very prevalent, and it's mostly prevalent in tropical regions and clearly in East Asia, Southeast Asia, Oceania. It's, so as I said, all over the world. It has more prevalence in disadvantageous population. We thought about the climates or the hygienic reason for its prevalence, but it's actually the overcrowd that it's really the main driver for the transmission. So people really living together and closely together. It has a huge impact with a global burden that it's quite high. It was underappreciated, but now I think it's quite more well known with the link with impetigo, with a link also with all the itch and what, how the itch can affect your life, affect your attendances at school, affect your brain and your mental health. So now it's quite well known, and for all those reasons, the WHO decided to add scabies on the list of the neglected tropical diseases in 2017. What about Europe? We said it's clearly a problem and an issue with migrants, that's for sure, because they all live together. And also in 10K homes, in the elderlies and when people live together. And in tropical and subtropical regions, as I said, is really an issue, a major issue in sole isolate islands in Fiji, Panama, Papua New Guinea, where it's really, really prevalent, as you can see here in this very good paper that come from Lucia, which is a researcher in Australia. In those regions, scabies is coming, so there's the mite, there's the itch that comes with the mite, but there's also a lot of other things that come with the mites, and it's impetigo and bacteria, mostly Staph aureus, but also Streptococcus, that actually causing a huge burdensome complications that can sometimes cause to death, but mostly with post-infectious diseases such as glomerulonephritis or rheumatic heart fever, which are still prevalent in those areas with a lot of issues, and especially in young kids. So what scabies looks like? I mean, I'm a dermatologist, so I'm always value a lot the pictures, and especially, you know, with scabies, it's really a large varieties of skin affections. Of course, we know the burrows, we know the papules, but there are actually a lot of different things, and especially if we come to the spectrum with, you know, scabies can be the hidden dermatology affection to the very not hidden affection with a lot of crust, which is crested scabies. But there are actually sometimes atypical scabies. And I'm very glad that Erin, she's a dermatologist in Australia, she has published this great paper on actually a new pattern of crested scabies that actually the crusts are reversed from what we normally observe when you have hyperkeratosis on the plantar. And it's actually because the mites are removed with the friction, so they are not where you should have some hyperkeratosis. And it's actually a sign that we observed together when we were doing remote consultation in Northern Australia. So I'm very glad that you put out this publication. The nail infestation, sometimes it can be isolated. So only one, two nail can be involved. So that's what was there in that publication. And actually also sometimes a quiz that I do a lot with the residents. Sometimes it's actually very hard to pick the right, you know, what's infect you. Is it fungus? Is it scabies? I mean, on that picture, you can imagine that may be easy, but maybe not. So I'm not leaving you the quiz for you, but I just show you the answers. And sometimes it's very tricky. Sometimes it's easy, but sometimes it's tricky, and it can be only one nail, a crusty nail. Atypical scabies as well is when the mite can come from animals. So there is a very great picture from a very great paper, from a great review from Barbara. She's a veterinarian in Italy, and she had put together a lot of articles to try to identify, you know, what is the burden of zoonotic scabies that it really exists, and what can be the lesions and clinical presentation in humans. So she has come up with this very nice review with showing that really the dogs are the species where it affects the most the humans. It's still rare episode. And the cool thing about it is actually from a clinical point of view, you can differentiate the scabies cases that may come up from animals. For sure, their history, what the patients are saying, but there are also some kind of differences where actually the lesions are where the dogs or the animal is in contact with the skin. So how do we make the diagnosis of scabies? I just show you that sometimes it's very easy on the clinical presentation, sometimes it can be harder. So do we really need to find the mite? And can we find the mite? So sometimes it can be really challenging, especially, you know, in those settings when you are a remote area where it's very difficult to access to, you know, high technology or just to sometimes a dermoscope, which can be sometimes easy, but not really easy on darker phototype. So the IX, I actually put out two great publications with consensus criteria on the diagnosis of scabies. And you can see that there are confirmed cases, but the clinical scabies and suspected scabies to allow us to try to have a cool clarification on the diagnosis. So how can we find the mite? If we really want to find it, you can do scraping, but you need to access a microscope. But there are also new modern tools such as dermoscopy, in vivo confocal, which is a very, very nice tool because you can see the mite moving in the skin. But of course, it's a very expensive technique, and it's mostly used to check melanomas and moles. And now there's sonography. I think it's a cool recent publication that actually showing that just a simple US sound machine can actually find the mite. There's also our publication that we were excited that maybe, you know, we can just scrape under the nail and try to find the mite. Unfortunately, it was not really, I would say, successful because the standard techniques were actually way much easier and sensitive to find the mites. But it's actually a good reminder that we can find mites under the nails. So nails can be a big reservoir and has to be treated in case of scabies. At least, cut short the nails. That could be an easy thing. And that also helps with the secondary infection. So remember to treat the nails. And also, does the itch could help for the diagnosis? That was an idea that we had with my mentor, Olivier, that were saying, I know them, when they are in consultation, they scratch a weird way and they scratch during your consultation. And that should be, a sign of scabies. So he had this idea. He wanted me to do crazy videos during consultation. That's Olivier, how he does, but I think it was a cool idea, but actually someone else did it, which is good. And actually showing that the patients are itching during the consultation. And that's when they do that, most of the time it's scabies and it's not another dermatosis. So that's could be just a clinical sign. And there are, of course, modern tools such as LAMP or PCR that are under development, and we hope to have those kind of easy diagnostic tests for scabies, but it's ongoing, but not really get there yet. How to treat scabies patients, because that's where we need to go. I mean, we really need to treat those patients. Very prevalent disease, some dogma for scabies. The tricky thing is that it's a full family that you need to treat. There's the eggs, the immature form, also the adults, and you need to eradicate all the mites to be sure that the patient is cured. We want 100% cure. If you leave 1 or 2 mites, then the cycle will be back and your patient will relapse. So it's eradication for your patient and the cure that you need to do. So you need to target the eggs that are sometimes very hard to get because they are really numerous. They have an immature nervous system, which is the target of most of the drug that we have. They are not mobile. The immature as well, they have an immature nervous system. And as I said, you need to treat all the mites, the eggs, the entire family. I mean, the mite family, but also the patient family. So all contacts and family contacts that a patient had, and also the environment. And for that, you need 2 successive treatments. Sometimes you need to combine topical and systemic drugs. You need to treat the contact and you need to treat the environment. There are 2 Cochrane reviews that are actually saying the same thing, 2010 and 2018, saying that mainly we have 2 main drugs, the topical permethrin and oral ivermectin, that it's better if you give 2 of those treatments, and that maybe topical ivermectin is doing as the same as topical permethrin and oral ivermectin. The main limitation for those 2 drugs, they are actually both quite expensive. They are not available in all countries. I would say ivermectin is, I know it's available in Pakistan, but there is a lot of countries where it's not. It's not approved. Sometimes the second dose is not approved, like in France. There is, for the topical drugs, there is a lot of cutaneous intolerability. So it's itching, it creates eczema. It's not really not easy to apply a topical drug from head to toe in a hot climate, and also in some places where it's overcrowded, you don't really have a personal place where you can apply the drug over your entire body, and you need to do it twice. So there's very poor observance to those topical drugs. And for ivermectin, it's not working on the eggs, so it's why you need to repeat the treatment. It's not a lot for people under 15 kilos. There's some controversies about pregnant women, about elderlies, and it's not for both of them. It's not 100% efficient. And for both, there is an emergence of resistance. So there is 3 papers about treatment failures. There's a lot of noise about the treatment resistance, or at least tolerance to treatment from permethrin, but also ivermectin. There's this nice paper coming from Korea that actually showing that limited mobility and topical steroid use prior to diagnosis was actually could be causes to treatment failures. Also, these 2 papers from Germany and Austria, the German one saying that, so it's a male survey and showing that there were not really a lot of cases of failure, but clearly in Australia, even with the intensive treatment with permethrin, there were quite a low cure rate and might have some case of resistance or at least tolerance. It was already reported by Kate Munsey, which is a great researcher on scabies. And she actually showed the data, but it's now quite old. It's 2006, 2007, showing that permethrin was working for sure very well, but not so well, and also showed some ivermectin tolerance. And I think it would be very, very important to have those numbers in 2022 and in different countries, and we might be surprised. In specific population, there is this wonderful first publication, and after many came after this one, about the first mass drug administration for scabies in an endemic population. It was in Fiji, showing that ivermectin was successful for this mass drug administration. They came up 2 years after this mass drug administration, and the rate of scabies was still very low. So it should be and could be a very efficient way to go, especially for those areas. There's a lot of ongoing work with that, and especially from this team from Melbourne in Australia. And actually, the good thing about ivermectin, it's also have an effect on impetigo, which is concomitant with scabies. Again, on specific population, there's a lot, as I said, on controversies on pregnancy. And there is this great systemic review and meta-analysis that are actually showing that all the data pulled, especially a lot in Africa, actually show that it was quite safe and might be safe to give ivermectin to pregnant women. We also, this viewpoint in plus NTD, actually saying that sometimes you have no choice. I mean, when you have a pregnant woman with a lot of eczematous lesions due to scabies, then it's not really appropriate to give topical drugs. So the only other way to go is ivermectin. And we are actually, saying that it's really something that we need to take into actions to allow ivermectin to those specific population. And also for the pediatrics, because it's still not really recommended, but there is a lot of data showing that it's actually maybe safe. And as well, sometimes you don't have choice and you need to give an oral drug because the skin is too painful or too affected. Then for the crested scabies, there actually RCT that is finished with the PI is Olivier Chaussiedov in Créteil, trying to see if oral ivermectin, but with a double dose of 400, might be more efficient on top of on permethrin and emollient cream. That actually try to treat those patients with very severe crusted and profuse scabies, and we hope to have results very soon. Spinosad has been approved in 2021 in the US to treat scabies. So it's the first FDA-approved treatment recently for scabies, and it's a topical administration. And there are moxidectin, which is a cousin of ivermectin, which is currently under development, and a phase 2A study has been finished. With centers in France and in Australia, and we wait for the results. Hopefully they will be good, and hopefully the development can continue. And of course, we need to address the itch, but I think in dermatology in general, I mean, there is a lot of presentation on itch at the EADV, and I hope, in some of all the new targets that we have, some will be useful for the itch, at least maybe not concomitantly. You need to make the diagnosis, you need to treat scabies for the itch, but at least to be able to address that. And and yes, just the two last points. Just the first one is that ivermectin has been listed on the list for essential medicine by the WHO, which is very important. And also ivermectin, as you know, it's a huge debate here, but was very, in the press with COVID. And we hope that, this drug can continue its path because there were a lot of, different things, but we hope ivermectin can continue to do great for those patients. And that's the thankful slide. Thank you all.
Charlotte, thank you so much, as expected, an absolutely brilliant summary of everything that's going on. And for those of you whose interest is piqued, there are 2 sessions tomorrow on scabies. One, scabies in migrants, and a migrant health session early afternoon at the main meeting, and also a whole session on mites and so forth. There'll be at least three presentations on scabies at that towards the back end of tomorrow afternoon. So that's great, and we'll take questions at the end, and it's all kind of sitting in together, isn't it? It's very, very exciting. So I'll hand over to Rosemary to introduce our next speaker.
Yeah, thank you also, Charlotte. I think we learned a lot. And thank you for the tricks. Now it's a real pleasure for me to introduce you to my dear friend Colette. She is a dermatologist at the Erasmus University Hospital in Rotterdam, and she was has been running a tropical dermatology clinic for 25 years now. So she's really experienced. She is the past president of the Dermatology Society of the Netherlands. She was the chair lady of the Tropical Task Force for many years. She is even a founder of that task force in the year 2014 in Amsterdam. And it's really an honor for us to succeed it. Colette and me, we are bonded through our experience in annual teaching dermatology for medical students in Malawi since almost 20 years now, including all ups and downs, I would say. So you will speak about Leishmaniasis. It's really a growing menace in Europe. Please, very welcome.
Thank you very much for that lovely introduction, Rosemary. My pleasure to speak to you today about cutaneous Leishmaniasis. And I think a lot of what Aisha said can be copied one-on-one on Leishmaniasis concerning the mosquito, the spread of the mosquito, the climate change, the migrating populations, and also the awakening, hopefully, of the necessity to do something about this, also this horrible disease. Not only the cutaneous, but the visceral and the mucocutaneous Leishmaniasis. So what I'll do is focus on the imported cases that we see and lessons learned from them and their complications, together with the problems abroad. No conflicts. This is the kind of cases that I see in my clinic. A boy, 12 years old, a long delay in diagnosis, was on a summer holiday in a dorm over a year before he presented to our clinic. And once a biopsy had been done in a different clinic, the diagnosis of Leishmaniasis was made. Okay, cutaneous Leishmaniasis. So what can you do? You can do a skin smear, histopathology, PCR, and in his case, we had Leishmania. The diagnosis was Leishmania infantum. And the next question is, how do we treat? Local, systemic, depends on a lot of factors, and I'll show you, we'll talk about those. In this case, the size was quite large. You could see the eye was almost closing. The localization was difficult for local treatment, and the subspecies with still a very high load of parasites after over a year, 1.5 years, made us treat him systemically with miltefosine in his case. And here you see the results a year later. He was lucky. He does have an atrophic scar, but it's not so bad in his face. So Leishmaniasis, the life cycle. We need the sandfly. The sandfly is a vector. The promastigote inside the sandfly, in the gut, in the midgut of the sandfly, is transported into the skin of the host, which is usually a mammal or a rodent, but sometimes a human being. And there, the promastigotes are phagocytized by the macrophages, the histiocytes, and are turned into amastigotes. They can divide again and again within the patient, and then they're picked up again by the vector and transported again to a mammal, a rodent, or a human being. So that's a cycle. This is what it looks like in live in the histopathology and the promastigote. Now, the outcome, Leishmaniasis is not an easy disease. It's very complex. There's very different outcomes. There's very different treatments. And what is the outcome determined by? The parasite characteristics. There are about 20 relevant subtypes of Leishmaniasis. The vector biology, you need the vector, which is in the world in different places, at different temperatures, in different populations, and host factors, and especially immunity. And in this day of time, we have many immune suppressed patients, we have many elderly patients, and that is relevant for the response to the infection. So again, here you see the cycle. Cutaneous Leishmaniasis, that outcome it's depending on the subtype and also on host immunity, a good cell-mediated immunity. It is the most common type. Visceral Leishmaniasis is the most serious type and is fatal unless treated in almost all cases, and then mucocutaneous Leishmaniasis. The vector, a phlebotomine sandfly. There are about 300 or more subtypes. About 70 of them can transmit Leishmaniasis, and the subtype, the group Phlebotomus found in the Old World and Lutzomia in the New World. They bite from dusk to dawn. Actually, you need to protect yourself all day. I really agree with Aisha on this message, and that will a lot of your problems will never occur. The resident host, small mammals, rodents, dogs. If you talk about Europe, in urban areas, it's usually a dog, could be pet dogs or stray dogs, which are the resident host for Leishmaniasis. And over 50% of stray dogs, for example, around the Mediterranean, are actually infected with Leishmania. And they can have symptoms like this dog at the bottom here, you see the lesion on the nose, or they can be asymptomatic. That goes for humans in endemic areas too, actually. They can be carriers and be asymptomatic. So that's important to realize. And people are traveling more and more with their pets, with their dogs. So they're going to these areas, get infected, come home with them, import dogs. So, and as climate change it makes more temperate climates more susceptible or more better areas for the vector to survive, the dogs will be able to spread through the vector, the Leishmaniasis to human beings. Okay, so I'm not going to talk about this, but I just want to mention it. Fatal, because it's such a big problem in countries like India and Brazil. Fatal and if left untreated. General signs, so you need a high index in suspicion, which luckily in endemic areas usually is there. And many cases appear. At the dermatology, we might see the post-gala azodermal Leishmaniasis after treatment or not treated visceral Leishmaniasis. This can occur, and it can appear, for example, with hypopigmented macules. So in endemic areas, I think the dermatologists know this very well. Mucocutaneous Leishmaniasis, especially by Leishmania brasiliensis, but also panamensis, for example, tend to the papers say 1 to 10%, but then nobody is really sure how often this occurs because the follow-up is really, really difficult. And all studies, follow-up studies, whether with treatment or without treatment, they are all so different and so varied in dosage and length of treatment. And in follow-up time, that is very difficult to say. But once it occurs, the patient has a devastating, mutilating disease of the nasopharyngeal area. What happens is that after the first cutaneous lesion or the first bite, the parasite travels to the with lymphogenically or hematogenically to the nasopharyngeal area and remains there. This can happen within a couple of years or maybe after 10 years. And a hyperimmune response develops, causing great inflammation and great damage. So in these cases, systemic therapy is always necessary, and patients at risk of respiratory obstruction also need steroids. So cutaneous Leishmaniasis, 0.6 to 1 million new cases per year. And these are the areas that are various, South America, the Mediterranean, Asia. Very much affected. This is a nice map, an interactive map that the WHO has online, which if you see a patient or if you're in an area and you're wondering if there's Leishmaniasis, This is a live interactive map. You can look up the country and it tells you exactly how many cases have been registered at that given moment. So for example, here I've looked up Syria, and you can see that there's many cases. Now, a full slide, but relevant. These are the most important subspecies of Leishmania causing the different forms of Leishmaniasis, Leishmania tropica, cutaneous Leishmaniasis, and they all have their own complications or possible complications. So in the case of Leishmania tropica is, for example, the Leishmania recidivans, and a mucosal form of Leishmania, which is usually develops per continuitatum. Leishmania major, cutaneous. Interesting for Leishmania major is that once you've been infected with Leishmania major, usually you develop immunity for life. So this one has been the major subtype of Leishmania, which has been looked at, for example, for the development of vaccines, which we'll come to, because this doesn't go for all types. Leishmania infantum, we see a lot of in Europe, Donovani, Ethiopia. That's all the old world. We still talk in all the publications about Leishmaniasis, all the new world. Then also infantum in Central and South America, causing cutaneous and visceral Leishmaniasis. And then there's at the bottom there the three subtypes, Viana, Leishmania Viana, and those three subtypes specifically are able to cause mucocutaneous Leishmaniasis. And these are things that are really important to realize when you see one of these patients, because the risk factors for these complications help you decide on your treatment. So diagnostic procedures, like Aisha, in endemic areas, you may have one or none of these, or some of these, and you may be left to have to go on clinical signs, local experience, local knowledge of subtypes of Leishmania that are subspecies Leishmania that are prevalent, etc. But what can we do? Skin smear taking, you can do the slit skin and scraping smear, the imprint smear. That's what I usually do. You take a skin biopsy, you want to do histopathology, and then you take that biopsy and roll it on a slide. And you can do direct color, a Gimsa or a hemacolor stain. And after 5 minutes, you have your diagnosis if it's positive. So that's really easy and really nice for residents as well. Final aspiration, if you have a deep lesion, you can inject some salt in and aspirate. What do you see? A blue oval organism, usually with a dark nucleus and a typical cytoplasmatic kinetoplast. And that's a larger view where you see the histiocyte, and here you see the two amastigoids with typically the larger nucleus and the smaller kinetoplast. If you see that, that's in a clinical question Leishmaniasis, it's Leishmaniasis. Histopathology, of course, varies according to also your immune response. You may have epithelioid cell granulomas with inactive CMI with very few parasites, so that makes it difficult to make the diagnosis. And you do have a differential diagnosis still in those cases. Or when you have decreased CMI, at the slide at the bottom, you can see that those vacuolated macrophages are really filled at the borders there with lots of amastigoids. The PCR, when available, is most sensitive. So it's if you have it, you could use it. And the nice thing is, over the last 10 years or so, we can also determine the subspecies. So that's really great. It's helpful. Culture is not used much anymore, maybe outside of research purposes. So you've made your diagnosis, then treatment options. There's local treatment options, systemic, and there's parenteral options and oral options. Local treatment, there's several guidelines from different areas of the world, and several publications which more or less say the same thing. Of the local treatments, the most effective is a combination of intralesional pentavalent antimony with cryotherapy. You can do either one of them separately without treatment, but it's more effective to combine both. The drawback is that it's pretty painful, so you may not be able to do this with everybody, because you want to do. Usually, I do up to 8 sessions, once or twice a week. So it's not like after one time you finished, the patient has to come back and do it again. Cryotherapy, other physical therapies, surgery, and paramomycin ointment, the most effective probably together with gentamicin. The drawback there is irritation and very variable results. Now, this is a busy slide, but just as a reference, for 70 or more years, the pentavalent antimonials have been around, have been effective. There is resistance. It's also high failure rates anyway, whether it's resistance or dosage problems, etc. And they're pretty toxic. They can be given IV and IM. Amphotericin, especially liposomal amphotericin B, is less toxic, better tolerated, and first choice if you need a systemic therapy, as compared to pentavalent antimonials in most settings. And pentamidine is also IV-IM for specific subtypes such as the Guianensis and Ethiopia. The oral options, miltefosine, is new, relatively new, originally an anti-cancer drug in India, which was shown if the patient was treated with this drug and the patient had visceral leishmaniasis, they were getting better. So it's actually used for more and more, very effective for many different types of leishmania, and also used for high-risk cutaneous leishmaniasis. Drawback, very expensive and definitely not available everywhere. The azoles, fluconazole and ketoconazole are easy to use, but also not very effective. You should not use them on complicated cases, but there have been some studies showing effect, at least. For example, take Leishmania major. It's just cutaneous leishmaniasis, but it can give bad scarring. So if you use fluconazole, it might heal faster and heal sooner and give less scarring. But it's not my first choice. Okay, another busy slide. Then we'll get to a number of the patients. Species. So what's important? The species. If you talk about simple cutaneous leishmaniasis, then probably you can use. Usually you can use local treatment. Complex leishmania, you need systemic treatment. So you need to look at species, size, number of lesions, location, prior treatment, spread, local or, of course, systemic, sporotrichoid, disseminated, recidivants, diffuse or regional adenopathy, and host immune status, which more often these days is impaired. Also, of course, locally, cost and availability, risk-benefit ratio, and patient age and preferences. A couple of cases. A leishmania major patient who he did not want another cyst. He had so many lesions that even though it's just cutaneous leishmaniasis, you could treat locally. He wanted systemic. He did not want a severe systemic treatment, so he was started on fluconazole, and he actually did well. Another lady with Leishmania major, tropica, with Leishmania tropica from Turkey, and she went on holiday. She came back with 12 large ulcers, painless ulcers. And there were so many, and they were in the face, that we suggested systemic therapy, but she delayed in coming back. And then when she came back, she was healed. So sometimes you get lucky, and her scars weren't that bad. This is a typical Leishmania tropica complication, little girl with a Leishmania tropica, Leishmania recidivans. She's from Aleppo, Syria. Her nose is scarred from recurring Leishmania at age 2, 3, and 4. And she's now 9, and she had lesions on the cheek where you can see the scars from previous activity and activity at the bottom there. She did not tolerate miltefosine, so we did treat her with intralesional treatment, and she took it quite well, and she actually did well. So risk factors: the malnutrition, population displacement, poor housing, immune compromised status, etc. what Lee talked about. If you look at the countries where people are forcibly displaced, and these are the top 10 a couple of years ago, you see that Syria, Afghanistan, South Sudan, Iraq, these are countries where there's leishmaniasis. So leishmaniasis is on the move. And this is an example of the trend of cutaneous leishmaniasis after the health system in Syria was devastated by the war. And you see the rise over the years. A case of mucosal leishmaniasis by Continuitatum from Ethiopia, pentamidine first choice. And this is a case of a lady, an elderly lady, treated for actinic keratosis. A persisting lesion was biopsied. They thought it was a squamous cell carcinoma. It was leishmania. Looking back, a year ago, she'd gone to Valencia. So a city trip to Spain or Italy can give you leishmaniasis. Then I was talking to her and she said, I'm seeing for the past 6 months, I've unexplained anemia, I'm febrile, I'm sweating at night. And so we thought, let's do the PCR on the blood as well, positive. So she had cutaneous and visceral leishmaniasis. Next question then is HIV. No, HIV negative, because 70% of leishmaniasis VL patients in Spain are HIV positive. She was not immune compromised, but she was probably her age. We decided that might have made her develop both. So this is a complication. You look at your patient as a whole, that may be there, even very slowly and mean. She did not respond to amphotericin, but she did respond to naltrexone. Another case that we would see often these days, somebody on TNF alpha inhibitors because of sarcoidosis. He had lots of skin lesions, which did well on triamcinolone, acetonide, or canalog injections, but one. This one persisted. And you can see the dates. So new investigations were done. He had a leishmania infantum, and looking back, he'd been to for a week on a motorbike around the coast of Spain a year ago. So he did okay on miltefosine, but it did not treat the whole lesion. He needed a combination treatment. Mexicana, just a picture, destruction of the ear. This is what it can do. And then this one I want to show you. This man had a primary, he had a leishmania in January 2017 from Suriname, Brasiliensis. He did not want systemic treatment, which we suggested because of the risk of MCL. So we treated him locally. He did pretty well. And then a year later, he came back after another visit with a new lesion. So the Brasiliensis did not protect him from developing a new one. And this is a typical location also on the toe. He was given miltefosine at that time. After 1 week, 4 weeks, and 6 months later, he healed nicely. And by that time, this was his arm as well. So I hope we treated him well enough to help him not develop complications later. Last slide. Prevention, of course, personal prevention, vector control, very, very important, and vaccines. We know the principle of leishmaniation, which was almost a century ago already, was people were injecting themselves with live or heat-killed promastigotes or whole parasites in order to develop a lesion on an area which was not so cosmetically important in order to protect them from developing lesions later. Problem is that you may later, when you become immune compromised, develop more serious complications. Also, it's very difficult to have a standard vaccination made out of that. There's lots of developments. It's really difficult because it's such a broad and complex disease. But knowing the DNA of the Leishmania parasite is going to help in combination with adjuvants, with a viral carrier, and the first vaccines have been developed. My take home, leishmaniasis. So it's growing, it's everywhere. have a really high index of suspicion. Let's hope, and the resident hosts are also widely infected. Let's hope that that there's more and more attention for this important neglected tropical disease. Thank you.
Colette, really, for this is very important. Please stay with us. We are ready for questions.
So we thought we'd ask the other two speakers up for questions too, and I'll move out of the way and run about with a microphone.
It's really important, I think, concerning our future, this talk, and also thank you for this complex and very interesting cases. Thank you.
Have we got any questions from our online?
Questions up to now, there are no.
No, there are no.
But the chat is open, but
No.
are there questions in the room?
Yes.
Thank you so much. Those were all fantastic talks. Colette, I had a question for you. Sorry.
Yes.
So fantastic, all three conversations, and so important. I was curious, so with us in the United States, I see, oh, here. Sorry. I promised my kids, last time I went to a conference, I came back with COVID. So I promised my kids I wouldn't bring them back COVID this time. So in the US, I see a lot of new worlds, leishmaniasis. And so many of our cases, when we speciate them, have risk for mucocutaneous disease. So usually the conversation I'm having with my patients is we need to systemically treat you. And they're very hesitant. Because often I'm trying to convince them to do many days of pentavalent antimony. And sometimes that means admission or coming into the infusion center every day for 20 days. And they're all very unhappy. And I show them pictures of, what it means to lose your nasal septum. And I show them pictures of mucocutaneous disease because I'm mean, but I'm trying to figure out how to wait till this is not a good way to convince them. But I'm curious to hear from you, I haven't used a lot of miltefosine. I've mostly been using pentavalent antimony when we have these high-risk cases for mucocutaneous disease. So I'm wondering if maybe I should be changing my approach. And I'm also wondering how you convince your patients when you have species that you are high risk for mucocutaneous disease, because I have a really hard time convincing them that this tiny little, lesion on their cheek is going to potentially lead to something really bad 10 or 20 years down the road.
Thank you, Esther, for that question. No, well, I have the same struggle. You saw the man with the toe and the arm and the toe. The first time I suggested, because it was quite a long-lasting lesion already, and quite a lot of parasites, I suggested treating him systemically, and he refused. Once they learn about the side effects, it's easier if you can use miltefosine, because the main side effect there is digestive tract and tiredness, which can be underestimated. But otherwise, and some, passing liver function perhaps. So those side effects are less. So I'm getting more patients on miltefosine than on the M4B. Sometimes it helps to say that liposomal M4B, is less toxic than the others, and it's only a few infusions, 3. The pentavalent antimonials are a struggle, but we don't tend to use them a lot anymore. So I agree, and I do sometimes show pictures too. Yeah. Yeah.
Any other questions? Yeah.
Online questions. Congratulations to the presentation.
So I have a question about scabies, because recently I know there's an outbreak in Lombardy apparently. What is the best therapeutical scheme, the most efficient one, if you're combining both systemic treatment and topical one? For instance, Ivermectin has become available in Italy just recently. So I'm just getting some experience on it. And if I can, I will give Ivermectin, and then 1 week later, I will tell the patient to perform a treatment with the permethrin 2 consecutive nights. What do you think about it?
That's a good question. I think there's not that much of recommendations. There's several questions in your question. So first, it's the timing between the two. So at least 2 two dosage. If you do topical or if you do systemic, you need to do 2. And the space in between, I mean, it's debatable, but I think it shouldn't be 2 weeks. That's too long, but it should be from 7 to 10 days, not less, not more, around that window. So that's for the first question. After the combination of both, I mean, it's debatable. For the moment, the recommendation is to choose only one. So either a topical, which permethrin or benzyl benzoate, or ivermectin, but not to make the association of both. After it's, you know, up to the physician. It's really, really important. So in my clinical practice, it's really consultation that take a lot of time. You really need to have a good list of the contacts. So for me, that's really the major points, is really have a very good understanding of your patients. Where do they live, with whom? You know, sometimes you have recomposed families, so you really need to understand, you know, who is the grandma, who is, where do the kids are living? Do they have kids or everything? So really understanding the family interaction. So that's helped a lot to be sure not to, you know, avoid someone, treat everyone. The environment is also kind of debatable in case of very, you know, of not really profuse scabies, but it's still a recommendation to do the environmental stuff. So to have also good explanation to your patients. And to make a consultation to make the follow-up to be sure that they are cured. So that's important. And then after, yeah, both to do topical plus ivermectin, I mean, I don't have very, sometimes I use it, but more for profuse, you know, that's in between common and profuse scabies. Sometimes I do it, but it's not really recommended for the current recommendations.
Hi, also for scabies, I wanted to grab you first to say I'm not a doctor and I'm new to scabies, but I come from a NTD background. So I know ivermectin is also used for LF, I believe, lymphatic filariasis. 7 things, many things. With LF coming more towards elimination, have the conversations about how resurgence of scabies might come in those countries been happening? I haven't been at those meetings. I don't know what the conversations are. And then as industry is making, will they continue to make ivermectin available?
I think and Claire, I think, yeah, please come in the conversation. I think clearly that it was a major milestone that ivermectin was listed as an essential role by the WHO, because in some cases it kind of protects the drug to be kind of well used and with good attention. We hope that the company will continue to produce it because it's, as we said, an essential drug. And we also hope that the entire, you know, big stuff that came up with the COVID also is now a bit, you know, it's behind us, at least on ivermectin. I'm not so sure, but we hope so. So yeah, that's my first comments. Let Claire come in. Yeah.
As we know, increases the adherence to mass drug administration cycles. So if you've got scabies in a community and you're trying to eradicate leishmaniasis or LF and you're coming back annually, if you've got scabies, they'll come back because their itch is better, whereas they won't bother coming back just if for the other condition. And from the point of view of actually making ivermectin available for scabies, that's going to be up to the countries themselves to pitch to their regional WHO offices to then make a recommendation to try and procure that. So there'll be an international procurement of ivermectin for scabies, we hope, or moxidectin, if that actually, which is probably going to be better because it's a once only treatment rather than ivermectin needs to be twice. So that's where the kind of argy-bargy is going on internationally.
We have some questions. Many people are congratulating to all the speakers. Then we have questions about scabies. The first one is ivermectin still recommended in prison setting? Prison.
In pediatric? Prison. Okay, sorry. Okay, but I mean, it depends on the countries, that's for sure, on the approval of the drug in each countries. And then after it's an easy, as we said, it's an easy oral drug rather than topicals. So, I mean, it's more for practicability, I would imagine, rather than, yeah. Most of the time it's how we choose, between the two. As I said in the Cochrane review, the results and the efficacy of both drugs are equivalent. So it's more, is it available, and what is your preference of your patient, and for practical reasons, which here it's yeah.
The IACS WHO meeting about what triggers mass drug administration in an environment. The recommendation is anything over 10%. So if you've got more than 10% of your community affected with scabies, that should potentially trigger. It's a recommendation. It's not evidence-based. It's just a group of experts getting together. But over 10%, you go for MDA. Under 10%, you go cases and managed cases. So that's also something to factor into that.
Yep.
And then what is the time between the two doses for ivermectin? I think we have said already.
Yep.
Another question is, do you use antiseptic soaps to treat scabies?
Not necessarily, especially because, most of the time the skin is altered. So, I mean, it's emollient clearly what you need to add on. Even if you do only ivermectin or oral drug, you should use emollient, which really helps with the itch and restoring the skin barrier. But I don't personally use soap, yes, but not antiseptic. And cut the nail.
We've probably got time for one more question. I don't know how many you've got, but maybe just one more. You pick it, Federica, no pressure. Choose the question.
They are all about scabies.
It's a big problem, yes.
So this is from Ethiopia, from Dr. Yared, and he's questioning about the efficacy of ivermectin. He says, it was mentioned single dose ivermectin efficacy was about 70%, but he says recent studies are showing much higher efficacy. Yep. What is your recommendation?
I think the results really depend on the population that you are talking about. If you take about single cases in randomized control trial, then that's one dose is around 70%. And if you go to second dose, then that go up to 80, 90%, sometimes more. And then if you take as a community, and especially for those big trials in Fiji, then actually we believe that one dose may be sufficient, but it's an entire population rather than single cases. So that might be the confusion here for the efficacy results.
Very clear. Thank you.
Break. I hope you'll be forgiving of us just extending over with those very interesting discussion points. But we don't want to eat into the next session. So we will be back here at 1:45 on time. I'm afraid we're eating into our coffee break. So I hope that's all right. And I hope that gives enough time for our online participants to zip off and do something and be back for the next session. So thank you, everybody. let's start going for the next session. And while I'm introducing our very important next speaker, I'm hoping that the last ones will collect together. So it gives me great pleasure to introduce our next speaker, who is Professor Esther Freeman. She is Professor of Global Health Dermatology in Boston, USA. I think she's the only Professor of Global Health Dermatology in the world, which is a first. She's chair of the International Alliance for Global Health Dermatology, or GLODERM, and she's going to tell us a little bit about that now. Thank you very much, Esther.
Thank you so much, Claire, and such a pleasure here today, especially to join forces with the EADV Tropical Dermatology Task Force. So we're so appreciative to do this joint meeting today, really we are, and the chance, especially for those of you that don't know GLODERM, the International Alliance of Global Health Dermatology, to tell you a little bit about us. So, let's see here. Am I pointing that way? All right, thank you. That worked. Fair enough. Great. So the International Alliance for Global Health Dermatology, also known as GLODERM, was formed several years ago, really with the idea of filling a gap where many of us that work in global health dermatology didn't necessarily have an easy place to come together and share. That's why it wasn't working. Amazing. Thank you. Have to use, this is what happens when you fly overnight and then you try to give a talk. You need to use the right remote control. Okay, fantastic. And so this really came out of a need of a place where those of us interested in global health dermatology could share knowledge and best practice. And so I wanted to share a little video that explains a little bit who we are at GLODERM. And we have a very easy bar of entry, which is you sign up to be a member. So all of you, before you leave today, I hope you can join us. So this is a small video just introducing the concept of GLODERM. Our goal as GLODERM is less about clinical training and more about how do we create the skills and the expertise to go out and change the healthcare system that they're working in.
About a third of the world's population have skin disease at any one time. There are some countries where there are no qualified dermatologists at all.
Not every country has a formal training pathway to become a dermatologist. So we want to improve access to education, but we also want to provide a platform or a forum to promote communication and dialogue and build networks.
Being able to find people, particularly in medicine, who can serve as mentors when you were interested in an area that not a lot of people work in, it is so important to really just believe that there's a pathway for you.
We built collaborations, we've built connections that we can use in the future. One of the objectives of GLODERM is also to link with all dermatologists from the whole world.
We're really hoping that everybody feels supported, included, gets the care that they need.
So we're easy to find online, and I certainly hope that we'll talk a little bit how you can join our efforts. And the idea really is to create a community for all of us working, especially with vulnerable populations and dermatologists and patients in low and middle income countries. Just to introduce myself, as Claire mentioned, my name is Esther Freeman, and I'm a dermatologist and epidemiologist based at Harvard Medical School in Boston, Massachusetts. And my background is really in global health, HIV, and dermatology, and now also in COVID, unfortunately, as all of us have experienced for the last 2.5 years, and now also in monkeypox. So we formed the International Alliance of Global Health Dermatology, GLODERM, and back in 2018. And the idea was really to create a place where individual people could come together. There are a lot of wonderful organizations, for example, the International Foundation of Dermatology that Claire runs, that are organizations that individuals can't necessarily join. And so the idea here was that if you are the only person in your department who's focusing on this area, you'd have a place where you could come together, and also a place for your trainees. It's kind of the organization that I wish existed when I was in training. So we went quickly, and unfortunately, all of us had to go virtual in 2020. And here we are today. And what we're so excited about, and actually using this meeting to announce our international mentorship program, which is just going live. And you are going to be the very first audience who gets to hear about our first class of mentees. And we're so excited to share that with you today. So we are now at over 800 members around the globe, and we have a very active GLODERM trainee committee, which is actually created and run by dermatologist trainees around the world, specifically aimed at providing free content for dermatologists and dermatologist trainees in low resource settings that may not have necessarily access to kind of high quality dermatologic teaching. So about a third of our members are trainees and residents, about a third of our members are faculty members, and about a third, so I should say a third is medical students, a third is resident trainees, dermatologists, resident trainees, and about a third medical students. And really, I think the three pillars of GLODERM coming together are our mentorship platform that we'll be talking about today, our education in terms of our webinar series, and community building, which all of you guys just being in the room together today is kind of part of our community building efforts. So I wanted to give you just some examples of things that our members are involved in. So we take zero credit for any of these. These are just active people working in global health dermatology. So for example, the World Scabies Program in Fiji we've heard about, in Moshi, Tanzania, the Albinism Outreach Program, the Helmut training program, the community dermatology program, for example, in Argentina, where I primarily work in Kenya and Uganda, looking at Kaposi sarcoma and HIV-associated cancers. And so really just, and social pediatrics, Wingfield Remus, who's our Secretary Treasurer working in Canada in Indigenous and low resource settings in Canada. So really just a variety of different programs that people are running around the globe. So I want to talk a little bit about some of our educational programs that we run at GLODERM. And so one of them run by our trainees is called our webinar series. This runs throughout the year with one free webinar per month. And the idea is that it's a trainee giving the cases, and then we usually have a world-renowned expert coming in to give a lecture related to those trainee cases. And these travel around the world in terms of different host countries. And so just to give you a sense of the example, for example, we had Nkosi Dolova in South Africa talking with one of her residents, Dr. Rufense Taboye, speaking about hair disorders. And we also had, for example, Chris Griffiths speaking about psoriasis. So we have people from around the world paired with a trainee in their country who are basically giving free, really high quality world-class content that's shared globally. I think one thing we actually were discussing last night is the challenge that many of our talks right now are in English. And I think one thing that we need to think about is how do we break down barriers in terms of translation and offering these in multiple different languages, because I think right now it is a little bit Anglophone centered. And I think we could probably do a better job with that. So we certainly hope that you will join our mailing list. You can hear about these free webinars. And for many of you that are already experts in these fields, we might be approaching you. And also just to let your residents and trainees know about these opportunities. And so we have recorded all of these lectures. We have a YouTube channel where these are freely available. And you can go to gloderm.org, which is our website. And so the GLODERM Trainee Committee, as I mentioned, is really run by trainees for trainees. And this is an international group. And you can see this is kind of how to reach all of our content for the trainees. So if you go to the GLODERM website and go to the Trainee Committee webpage there. So that's just kind of some of our educational content that we offer for free that we're going to continue to expand over time. What I'm super excited, this is like our big reveal for the day, so I'm just so excited you could all be here for this, is that we are launching today our International Mentorship Program. And so these are for dermatologists and trainees from low resource settings around the world. And the idea here is it's really filling a very specific niche. So this is not clinical training. So we're not necessarily training someone in how to manage vesico-bullous disease. This is for someone who says, I'm working in a country and there is no residency training program in dermatology in my country, and I want to start a residency training program. How do I do that? Or it's for someone working in a country saying, you know what, there's a huge issue with albinism in my community. I want to develop an albinism outreach and treatment program. How do I set up that program? So I kind of view this as almost what you didn't learn in derm training, which is how do you negotiate with the government? How do you pitch to a funder? How do you really create leaders in their own countries who are tackling their own problems? This is not us coming in saying you have an issue with X, Y, or Z disease in your community. This is really tell us what the problem is in your particular community and how do we give you the skills to tackle that. So with that, we're very lucky to have funding through Cerve for this inaugural class of mentor and mentee pairs. So we have 7 individuals for our first class from around the world. They'll have a chance to have a one-on-one experience with their mentor in their mentor's country. Again, not so much learning clinical skills, but more more, how do you develop a program, sell a program, how do you pitch a program, how do you work with different people to make that program a success and have it be sustainable. And then we'll also bring those, all of our mentees to the World Congress in Singapore. So I certainly hope to see you in Singapore and you can get a chance to meet our first class. So and I apologize for showing multiple videos of myself, like totally embarrassing. So I apologize. I opened this video as well, but I promise there are other people that are much more interesting than me. But I wanted to give you just a short snippet, I think even better than I can explain, about the creation of the mentorship program. And then you'll get to meet our first class of mentees.
We built this organization to be a space where people could collaborate, find mentors, find inspiration, read publications, interact and engage with other trainees to improve skin health worldwide.
It's unifying people with interest in moving something in global health and giving a platform to these people. The mentorship program is not to train somebody in my job, but to train somebody in being a global health leader.
There are three main components of our mentorship program. The first is an individual mentee-mentor relationship that will last far beyond the program. And by having a 1 month, whenever possible, in-person component of the mentorship program, really getting the chance to see on the ground and being involved on a day-to-day basis. So when you have these experts and you're able to match people up one-on-one, you can both grow the community and also really grow that individual who themselves can have a really big impact on dermatologic care worldwide. The second is a curriculum in terms of really developing the individual mentee in terms of their leadership skills, capacity building skills.
They can guide you on whatever path that you're really interested in because they know other people who have done the same thing and maybe done it a little bit differently based off of their skill set and their desires for their career.
Understanding how to best lead a room and lead a group is really important. Additional areas include training in grantsmanship. So for example, writing a grant. How do you take what you're doing and write it up in a publication in a way that can be shared on a worldwide stage? Being able to share the experience of someone who's been through that before is really invaluable. And the third is to build a community of mentee-mentor pairs that will grow over time in terms of our community with global health practitioner expertise.
I've been very fortunate to have a multitude of wonderful mentors like Esther and Claire. What I've always admired is that they're both incredibly accomplished and successful in their own careers, but they always make the time for their trainees and for juniors or for anyone really interested.
So many of the people who are part of GLODERM became part of this family tree, mentors on different levels and in different areas and at different stages.
We build collaborations, we build connections that we can use in the future. So I think one of the objectives of GLODERM is also to link with all dermatologists from the whole world.
The sign of a good leader is not how many followers you have, but how many leaders you create. And I think that's really the idea that we're trying to embody with the GLODERM mentorship program.
And in this spirit of trainees, I actually want to introduce you to one of my trainees, one of my medical students who's with us today, Alexis, who's in the back. And she's very rapidly trying to live tweet this in your entire conference. And so if you see her rapidly tip-tapping away, thank Alexis for trying to share the content on social media. So with that, I think the video kind of explained the concept of our mentorship program. And I wanted to introduce today for the first time, our first class of mentee. I'm like totally gonna get emotional. This is really exciting for us. It's a program that we've been working on for several years. So to really introduce our first pairings and to invite all of you to really become mentors in your own right for many of you in this room who are such experts in global health dermatology. So Luisa Silveira, who comes to us from Brazil, and she's active in our GLODERM community, and she's specifically interested in low-cost vitiligo and also is specifically in educational outreach projects in Brazil, and we're pairing her with Dr. Winat. Dr. Jared Mekinen, who actually asked a question earlier today. I was so excited to hear that Jared is online with us. So he's based in Ethiopia, and he's joined the mentorship program, particularly looking in Ethiopia and neglected tropical diseases. And we've paired him with Dr. Singhal, who's based in India. We have Dr. Lucia Fernandez, who's based in northern Mexico and particularly interested in vulnerable patients and migrants and approaches to refugee medicine across the border. And we've paired her with Dr. Fuller. Dorian Sabushimike, who you heard on the video, who is who's from Burundi, currently doing her dermatology training in Moshi, Tanzania, and she'll be traveling back to Burundi and working particularly in albinism in her home country. And she's one of very few dermatologists in Burundi, and she's paired with Dr. Toby Maurer. We have Marlis Krishnan, who's originally from the Netherlands, who's currently living in Indonesia, and we'll be talking really about kind of access to care in Indonesia and how to, Marlis is someone who are really training herself as a mentor to kind of lead the next generation of dermatology trainees globally. And she's actually paired with me. We have Gaylord, who's a really incredible individual who trained in Tanzania and who is working in the Democratic Republic of Congo in the DRC. And Gaylord is really interested in kind of getting additional grant funding and really working in skin cancer and albinism in the DRC, just an incredibly underserved area. And we've paired him with Dr. Wingfield Remus. We have Dr. Oyage, and Dr. Oyage is an example of someone who's working to create a residency training program in his home country of Ecuador, where he's actually currently the chief of dermatology in his particular region in Ecuador, but there is no dermatology residency training program in Ecuador. So we're working to give him the skills to really create a residency program in that setting. And he's paired with Dr. Dudiak, who's based in Israel. So with that, sorry for getting so emotional, but I'm like so excited to share with all of you guys. So to learn more about our mentorship program, if you go to our website, which is gloderm.org, we have a tab for our mentorship program. And we're very excited that we're going to be actually opening applications to our second class very soon. And the reason for that is we are excited to have the opportunity through CERAVE funding to bring both classes of mentees to Singapore, to the World Congress, to meet each other and to basically have 1 year that's finishing and 1 year that's starting. So everyone will get a chance to kind of meet each other and network in Singapore. So the reason I bring this up is that we're going to be opening applications to the second class probably in December or January. And so if you have people in your network, particularly based in low resource settings that you think could benefit from this kind of mentorship, we would definitely encourage you to keep an eye out. We'll be sending out the announcement to our listserv, which I'll show you in a moment how you can join, but just to kind of keep your eyes open because there may be people in your community that you think would benefit from a kind of official, you're probably already mentoring them unofficially, but if you feel that some official handholding would be helpful, we would love to do that. And I'm also encouraging many of you in this room to join us part of our mentor pool. So what I showed you was just a small group of our mentors. So we basically have a larger mentor pool. And each year, as we select the mentees, we actually pair them with someone who we think particularly we've chosen to go with that particular mentee. So you might be part of our pool, and it might be that it's not till year 3 that the right person comes along and we say, oh, this would be a perfect fit for you. So one thing we'd like to offer is some leadership training and mentorship training for our mentors themselves. So we would encourage you to join our pool. We will never assign someone to you without checking with you first, because you might say, you know what? This is like not a good year. I'm super busy this year. Next year will be better. So we will never just like assign to someone to you without checking. But please, we encourage you to be part of our mentorship pool. And so if you click online, there's an easy way to join our mentorship pool. So how do you stay up to date? And we basically send information, for example, about this meeting, about all the different meetings that would be relevant in global health dermatology. It's very easy. There's that little button that says join our mailing list. You click right there and we ask you very little information. We literally ask you to fill out like your name, where you work, and kind of what your area of interest is. So, and you really can't beat our membership fees, which are free. So we would definitely encourage you to, if you have not, you can, even before you leave today, you can join our mailing list. And so with that, we're so delighted to be here and partnering with the Tropical Dermatology Task Force. We're continuing to expand our membership worldwide, increasing diversity and representation in our leadership. And we're so excited that we are launching our mentorship program really as of today. And so with that, I want to thank the many, many partners that we have in funding our efforts, to our steering committee, to our GLODERM advisory board, including, for example, Colette Van Hees, who's sitting right here, Helmut Bertranelli, who you saw in the video, who's part of our steering committee, and to our wonderful ILDS staff who's sitting in the back row that funds and supports a lot of our work. So with that, I would say thank you so much. And I really appreciate the opportunity to speak with all of you today.
Thank you very much, Esther. And it's great to have that opportunity to share it with you all about GLODERM. Well, and I'll hand over to Federica to introduce our next speaker.
Yes, I'm happy to introduce to you Andreas Montag. He's co-chair of the task force. As we said before, he's working in Hamburg, and he's also a teacher in Sri Lanka for students, and also in Germany. He's teacher about tropical dermatology. His main interest since many years is the tropical dermatology, and in particular poisonous animals and poisonous plants, and also nutritional deficiencies involving the skin. Today, he's going to tell us about insect bites, right? Welcome, animal bites, sorry.
That's it. Thank you very much, dear Federica. This gives me the opportunity to say many thanks to you and to Rosemary. It's an honor and a pleasure to work together with you in this board. And thank you as well for you, Claire, and for you, Colette, for your ongoing support through all these months. That was really a pleasure and was really enriching. The disclosure of interest, everybody had time enough to see that I have no conflicts. After the obligatory duties, dear colleagues, traveling abroad or working as a tropical dermatologist far from home, or doing just both, means to face challenges. You will meet new people and you might experience new cultures. But what about the idea you might wake up after your first night in the tropics, opening your eyes after a deep and recovering sleep, and the first thing you might directly look at is this. Nose to nose with an exotic spider. What a morning. Wouldn't it be nice to know at least whether this 8-legged creature is just a nice lady or more sort of a venomous widow? During the next minutes, I won't, of course, ask you to catch animals. Let's just go for hunting diagnosis. To warm up, let's start with something worldwide common, a collection of circumscribed reddish skin changes. Itching or burning, single or multiple, some swollen, some blistering, and all out of the same summer. What do we see here? Well, in fact, these are stings of bees or wasps. All stinging insects belong to the order Hymenoptera, are represented by more than 150,000 different species worldwide. Less than 1% of them is responsible for stings in humans. Medically relevant are wasps, bees, bumblebees, and ants. Only the females sting. Their former ovipositors have been modified for stinging and envenomization. Let's start with the bees. This is the domesticated, harmless, and cozy-looking honeybee of European latitudes. In contrast to that, look at this creature, obviously in a very bad mood, and with his sinister-looking eye announcing nothing but trouble. The East African Highland bee is a subspecies of the Western honeybee, but in contrast to its Western relative, it is aggressive beyond any comparison. Its habitat is the mostly dry and meager highlands of Kenya, Tanzania, and South Africa. During a real attack, the barb-equipped bee sting rips off the firmly attached venom gland. This kills the bee. The domesticated honeybee knows this well and only stings in severe cases of emergency. Compared with this, the African Highland bee is sort of a kamikaze. It stings at any price. The most important components of the bee's venom are familiar to each of us. Allergologically important are just 3 of them: melittin, phospholipase A2, and hyaluronidase. Besides the common wasps of Europe, there are numerous other species worldwide who are not easily to classify as wasps for the untrained eye. Chalybdion samareni, besides the African killer bee, is another typical representative of tropical Africa, but unequally mild-mannered. With its brown color, it's difficult to identify for us as a wasp at first glance, but the abdomen represents a rudiment of the typical black and yellow wasp dress. While melittin is bee-specific, the wasp-specific component is phospholipase B. Phospholipase A and hyaluronidase at the same time are the major allergens in the bee's venom. The first aid treatment for allergic reactions against bees and wasp venom does neither need further remarks nor do the diagnostic and therapeutic options. What do we have here? Severe burning and hurting, reddish papules, some forming non-follicular pustules. So this patient was visiting a forest region. What you see are the typical skin changes of ant bites. In this case, made by a fire ant named Solenopsis, a small insect with an extraordinary natural-born killer instinct. Indeed, before starting the venomous attack, a fire ant grabs its strong claws deeply into the skin and locks in firmly. After that, the attack starts. Fire ants sting from the opposite end, and they do that in a completely disinhibited way. More and more, again and again, not stopping before their venom gland is empty. 80 years ago, the fire ant Solenopsis forced its way all along from Argentina to the south of North America, not hesitating to kill every other ant species getting in its way. Ants are relatives of wasps. In this aspect, the fire ant is no exception. The venom of all myrmecines contains hyaluronidase and phospholipase A2, which is exactly the same in wasps. And this is the reason for the very rare but severe cases of cross allergies between myrmecines and wasps. Fire ants additionally contain an alkaloid called solenopsin, causing the painful inflammatory skin trouble. What is this? Take this little hint, which proves it as a spider's bite. Most spiders are completely harmless for human beings, and most of all reports about registered spider bites are wrong and not caused by spiders. They are just a product of imagination created by the uncountable amount of arachnophobes worldwide. The venom gland, hardly harmful for man, is located underneath the eye and leads the venom directly through the fang. Most tarantula, or as you may call them, bird spider bites, induce hardly more than the effect of a wasp sting. But those you see here inject strong neurotoxins and bring the victims directly into the emergency unit of the next hospital. Hermit spiders are often counted to the family of spitting spiders. The common characteristics of this family is the third pair of eyes. Also, they are known for severe inflammatory bite reactions, often with necrotic skin changes. Especially the Loxosceles spiders of the Americas are feared for that. What do we have here? See the skin marks looking like a contact reaction similar to a creeper lane. Why do we find this irritation predominantly in the neck? Welcome to the world of beetles. This little chap only measures less than 1 centimeter, but as we just saw, it is able to provoke lots of trouble. Blister beetles can be found on all 5 continents. Beetles like Pederos are completely harmless as long as they scuttle undisturbed on the skin. But you better not squeeze them while trying to chase them off. Their toxic hemolymph leads to an extraordinary contact reaction on the affected skin with blistering and deeply infiltrated inflammation. So this defense mechanism is not at all a bite, and a possibly assumed bite mark in this case is nothing but a toxic contact reaction. Dog bites account for tens of millions of injuries annually and for over 50% of animal-related injuries in people who are traveling. In the US, for example, approximately 4.5 million people are bitten by dogs every year. Of these, nearly 900,000 seek medical care. 30,000 have reconstructive procedures, up to 20% develop infections, but between 10 and 20 fatalities occur. An estimated 60,000 people annually die from rabies. Bites from rabid dogs account for the vast majority of these deaths. Post-exposure rabies treatment, according WHO, offers two possible regimens. The most popular is the Essen scheme, as we call it in Germany, consisting of 5 injections, 1 vaccination dose per day, 0, 3, 7, 14, and 28. Worldwide cat bites account for 2 to 50% of injuries related to animal bites. They are commonly second to dog bites in terms of incidence. Female adults, even among travelers, have the highest rate of cat bites. The treatment is the same as in dog bites, including post-exposure rabies treatment and antibiotic prophylaxis for bitten people. Monkey bites account for up to 20% of animal bite injuries. In India, for example, 2 studies found monkey bites to be second to dogs as the most common source of animal bite injuries. Monkey bites are an important risk among travelers. As in bites from human beings, wound healing disorders are most likely. Travelers should be informed about the risks of monkey bites and prevention techniques, as avoiding getting closer company, like this lady here. But even in such a situation, avoid also to react aggressive. The monkey might strike back. Travelers do not only walk, many of them travel for purpose of enjoying the beaches and the underwater world, even in tropical countries, bathing, swimming, and diving. As apnea or scuba divers, travelers get into contact with lots of marine animals. Contacts from a distance, mostly nice, but getting too close, the situation might change into something unforeseen, snappy. Bites from a moray are not toxic originally. Morays do not carry real venom glands, but as they prey upon carrion, the moray mouth is full of bacteria, causing deep infections and wound healing disorders. What do we have here? This is, by the way, the last clinical picture of my presentation. The picture shows the clinical signs of a snake bite. One of estimatedly 2.5 million snake bites worldwide. About 125,000 of these end fatal. This here did not. It's a typical bite for self-defense, superficial and performed just with one of the 2 teeth or so-called fangs of the snake. The cut was done by the man, the patient, the victim, belonging to this finger as a traditional try to get out the venom. In this case, this rattlesnake was the reason for the just presented finger bite. It is a Tamaulipas rattlesnake from Mexico. Its venom is of medium-high toxicity. Medium-high toxicity means eventually loss of fingers, toes, or extremities, but usually not loss of life. What makes this case special is that this case happened in Hamburg, and this patient was a patient of mine, breeding venomous snakes. The Tamaulipas rattlesnake he had caught himself in Mexico as a traveler and brought home to be later on bitten in his own house. Snake bites in travelers usually happen in the early cold morning when the snake is still too stiff to escape, but already warmed up enough to bite, and travelers step on them accidentally, or in a brainless moment try to catch them. In this case, a single second during the feeding procedure with a lacking in concentration on the side of the patient was enough for the snake to attack him. All vipers or adders are venomous without exception. Elapids in particular are venomous to the utmost. But the majority of colubrids is harmless. The fangs of rattlesnakes, as of all vipers and adders, are extremely long. Therefore, they had to be folded inwards, more precisely folded towards the viper's throat. Cytotoxins in the viper's venom lead to massive edemas and later to a massive necrosis of the affected tissue. Hemorrhages in viper's venom lead to a disseminated intravascular coagulation and consecutive to a massive internal hemorrhage. Vipers, and with this also rattlesnakes' venom, contains antihypertensive kinins, leading to a cardiovascular collapse in addition. Neurotoxin lead to paralysis and are hardly found in most of the rattlesnake species. Definitely there are none in the Tamaulipas rattlesnake. Horrible consequences of rattlesnake bites occur every year in the south of the USA. Sometimes fasciotomy and extended plastic surgery becomes unavoidable. With the advisory support of local tox centers, a patient should be sent immediately in a qualified clinic, ward, or institute for tropical medicine. It is of central importance to identify the snake's species correctly. Please note, a patient having been bitten by an exotic snake always is a life-threatening emergency case until proof of the contrary. Never cut in a snake bite wound or suck it with your mouth. Never compress or strangulate it. Forget everything you might have learned about first aid in snake bites by watching Wild West movies. Smallest injury of their oral mucosa, even at that time, had brought even the most ambitious first aid helpers into severe trouble many times. In those cases where an antivenom is needed, Crofab at the moment is the most tolerable and at the same time the most effective antivenom for snake bites of vipers. Why that? This drug contains pure fat fragments from sheep serum, which have been generated out of venom-specific immunoglobulins. My tongue is falling in. FC units responsible for cytotoxic side effects caused by direct activation of the complement system are missing in this modern antivenom compound. The healing process of my patient from bite to restitutio had luckily ended with a recovered but slightly smaller and a bit numb little finger pulp. In every bigger town all over the world, there are relevant numbers of keepers keeping venomous animals or poisonous plants. Statistically, every dermatologist in own practice might be confronted at least once with a severe accidental injury of your own hometown area caused by, for instance, venomous animals. And if so, it could be life-threatening, so you better be prepared for travelers and for those who stayed at home in times like these. Thank you very much for your listening and for your participation.
Thank you very much, Andreas. So the next speaker could not come here today, unfortunately. He is Aldo Morone. I think he doesn't need any presentation, but let me say some few words. He was previously director of the National Institute for Health, Migration and Poverty in Rome. Now he's a director of a San Gallicano hospital in Rome, and he was the founder of the Italian Dermatological Center in northern Ethiopia, who was there for like 6 years. And he's also experienced with migration because he was following some projects in refugee camps, especially in Lebanon. And we will see his presentation now about the link. It's very interesting, the link between migration, climate change, and skin diseases.
Dear friends, dear colleague, first of all, I would like to thank all of you for inviting me here for this very important seminar on climate change, migration, and skin disease. I apologize for not being physically present, but anyway, I want to participate in some way. This is our experience from 1980 that we are working in many low-income countries, as well as Ethiopia, Burkina Faso, Libya, Lebanon, Kurdistan, Mexico, Cuba, India, and Afghanistan. In Tigray, especially, we opened 3 hospitals and 2 dermatological centers. This is our Sangalican hospital, was founded in 1725 by the Pope Benedictus XIII, and you can see here the Professor Ten Saraya, Bernaus, Aisha Seti, Rod Hay, Claire Fuller. We were here to write this important guideline on the role of skincare in the management of mobile population. This is our experience. We work with undocumented immigrants, refugees, homeless, abandoned children and adolescents, Roma people, retired poor people, women and girls with female genital mutilation, victims of torture. And we decided to take care of asylum seekers, all the poor people, trying to welcome them and putting their wounds and the fragments of their lives together again. Taking care has been a more complex clinical and anthropological experience than caring or prescribed drugs. Now we have 1 billion people in the world. They are on the move. There are an estimated 281 million international migrants, and internal migration is most prevalent with more than 740 million people. But this so-called migrant crisis, not a crisis of number, is a crisis of policy, it's a crisis of justice. And now we have also 94.7 million people, all refugee people. And among them are nearly 21.3 million, over half of whom are under the age of 18. Nearly 1 person is forcibly displaced every 2 seconds in the world. This is the global report of the United Nations HCR with 94.7 million of refugee people. The journey is very long, as you can imagine. It can last days, months, or even years. This is Lampedusa. We worked many years in Lampedusa, and usually I think Lampedusa as Ellis Island in the 18th century, landing migrants. This is the Ellis Island. This is inside Ellis Island in New York States. This is the key migrants routes from Africa to Europe. You can see some people coming from East Africa, West Africa, and you can see that a lot of people, they try to arrive to Lampedusa. Lampedusa is close to Tunisia and Libya, then Malta, that is far from Libya and Tunisia. So Caesar is the promised land for thousand migrants. They arrive in this way. We work many years in Lampedusa. This is the center for welcome people coming from Africa. This is our experience, and usually I would like to highlight the words of Pope Francis. I dream of a Europe where being a migrant is not a crime, but it sums to greater commitment on behalf of the dignity of every human being. So we have a lot of promise with the bars that affect so many people, children and adults like this. You can see this picture. So we have to work with them in the center of Lampedusa or in Rome. This is our experience in the dermatological hospital in Tigray. The second one is the Highland Hospital in McKellar University. This is the Shlaro Mario Mayani Hospital on the border between Tigray, Ethiopia, and Eritrea. And some short clip of Grand Hospital.
You have to avoid the mosquito here, huh? The mosquito. Yes, for the title or for the next one. Hmm?
Now in Tigray, as you know, it's impossible to go, but anyway, I would like to invite to come anyway to Ethiopia in other way. Climate change, skin diseases, climate factors can influence many skin conditions, can affect the incidence of a chronic disease such as atopic dermatitis and psoriasis, but also Maniases and other infectious skin diseases. I would like to show some picture about our experience with the cutaneous and mucocutaneous leishmaniasis. Is a great, really great disease with more than 12 million people affected in 88 countries. There are different forms, the visceral, mucocutaneous, and so on. We have diffuse cutaneous leishmaniasis occurs in an allergic host with poor immune response. So you can see plaque, ulcers, and nodules. You can see other picture about our experience on mucocutaneous and cutaneous leishmaniasis, sometimes in different diagnoses with the leprosy, like in this case. And this is a picture coming from leishmaniasis from Lebanon, from the Syrian refugee camps in Lebanon. You can see that is very different from the leishmaniasis cases that we observe in Ethiopia. And also, in spite of the common perception of association between migration and importation of infectious disease, there is no systematic association. And the communicable diseases are associated not with migration, but primarily with poverty. Like this, they arrive in this condition. A lot of migrant people, they became homeless people, tinea corporis, so many different forms of mycosis. You can see here, tinea corporis, genital warts, impetigo, HIV infection, herpes zoster, and a great problem about scabies. Scabies is a very important neglected tropical diseases. You can see scabies with impetigo, scabies with denutrition. Onchocerciasis is in different diagnoses with the scabies. Like you can see here with the onchocercoma, lymphogranuloma venereum, sex transmitted infection, and also the poor tuberculosis cycle, malnutrition, poor TB is a terrible, dramatic cycle. And you can see some form of scophoderma, tuberculosis cutis colliquativa, and other picture. This is one patient that we had the opportunity to have a good follow-up until he recovered completely. The cutaneous ulcerative TB, also in this case, is not easy to have this opportunity to have a follow-up of the patients with tuberculosis, porotychlosis, and lupus erythematosus, psoriasis, and I would like to highlight that we don't have any biological drugs in this case, so psoriasis and HIV infection. This is the capping. Capping is a traditional medical practice, very common in Africa, not only in Asia, but also in immigration communities in Italy. You can see this picture, and the diagnosis usually is not very easy. The female genital mutilation, I would like to show some picture because, as you know, in fibrillation, it means female genital mutilation. because in Latin fibula means a pin that was used to hold the toga in place, but in reality, in Roman times, the fibula pin was used to physically prevent male and female slaves from having sexual intercourse. This is the prevalence, the classification, type 1, type 2, type 3. You can see the picture after the female genital mutilation, and this is some clinical picture. You can see that here the vaginal opening is almost closed, but the problem is the association with HPV virus and cancer and female genital mutilation. You can see that human papillomavirus is very frequent in Africa, and also you can see the difference between Italy, 6.9 for 100,000. In Malawi is 68 for 100,000. The same is for female genital mutilation and HPV virus infection. The women with the female genital mutilation, they have 14.5, women without is 8. And so this is the same with the high-risk human papillomavirus common among a cohort of women with female genital mutilation. This is the great problem. And Aisha Sethi, she wrote a very important paper about this, also the risk of self-transmitted infection in women with the female genital mutilation. Climate change and pollution affect the skin is very important to remember that it's a great problem, and we have some studies, but we need more studies on the effects of climate change on the human skin and on migration. There are very good paper, and the conceptual framework of the impact of climate change on the skin disease, of migration and displaced population. But we have to remember the importance of the people, very poor people, because the climate impacts will affect the entire global environment. Water availability could decline. Human health could suffer from a combination of water shortage, malnutrition, skin diseases, infectious diseases, and loss of life, injury, mass population dislocation, and economic devastation of poor countries.
Pakistan is underwater in catastrophic floods. Raging waters have left behind a trail of death to both humans and livestock, while destroying valuable crops. Over 33 million people have been affected with the destruction of their homes built with blood, sweat, and tears.
Only a few days ago, we observed this drama in Pakistan. So the problem is also the gender climate change connection. Women are more severely affected by climate change and natural disaster due to social roles, discrimination, poverty. Women are sure underrepresented in decision-making about climate change and also about discussion and decision about adaptation and mitigation. Also, another problem is desertification. And desertification can have a great impact on the movement of the people, not only in the future, but also just now. You can see in this picture how many places with desertification on our planet. And this is our experience in Dengue. The Danaric Depression is the hottest place in the whole Earth in terms of year-round average temperatures. And it is also one of the lowest places on the planet at 100 meters below sea level. And without rain for most of the year, you can see also for the animal is very difficult. Only camels, they try to survive there. Climate change, it means increases in skin cancer. So I show you some picture about the skin cancer, let's say basal cell epithelioma. Epithelioma, you can see here skin cancer, pigmented basal cell epithelioma, malignant melanoma, nodular melanoma in patients in children with Xeroderma pigmentosa. Xeroderma pigmentosa is a dramatic condition on the tropics, so it's very difficult to live, to survive with Xeroderma pigmentosa in the tropics, in the equatorial area. So The poorest countries are the ones who pay more the burden of the climate change consequence, even though they have less responsibility in determining the problem. So another problem is the hunger. Migration, climate change, and skin diseases are food insecurity. So climate change means hunger. Hunger will be one of the major impacts of the climate change. It may be the defining human tragedy of this 21st century. You can see the picture in our hospital in Tigray, in Ethiopia. Normal malnutrition, so many pictures about diseases, kwashiorkor is a special diseases in Africa, sub-Saharan Africa. A water shortage. Half of the world's population will live in areas with a water shortage by 2030. You can see how it's possible to survive in this way. And also the access to water. The water costs nothing for those with everything and everything for those with nothing. The price of drinking water is very high in Colombia, in Ghana, than in New York or in London, in the UK. You can see here. They collect water here and they drink this water. So another problem, let me speak 2 minutes about a very painful drama for me, the war in Tigray, the region where we were welcomed by brothers and the colleagues over 40 years ago. Color of the skin, Dr. Tedros.
Humanitarian crisis in Tigray is more than Ukraine, without any exaggeration. And I said it many months ago, maybe the reason is the color of the skin of the people in Tigray. I haven't heard in the last few months, several months now, even a head of state talking about the Tigray condition anywhere, in the developed world especially. Why? I think we know. The only thing we're asking is, can the world come back to its senses and uphold humanity? If it's the worst humanitarian crisis, and I'm saying nowhere on earth 6 million people are sealed off, nowhere, from basic services, from their own money, from telecom, from food, from medicine. This is the worst disaster on earth as we speak. I'm from Tigray. It's not because I am from Tigray that I'm saying this. That's the truth.
Nowhere for people from Tigray. That is the drama. And also Tigray's medical system has almost collapsed. So anyway, I would like to invite all of you to come for this International Congress, Tropical Neglected Skin Disease, Global Health and COVID-19 Pandemic in Ethiopia, in Addis Ababa and in Wolaita Sodo University in Ethiopia. I would like really to invite to come, because we have the opportunity to meet each other, to discuss, and to try to improve the quality of the life of the people living there. As you can see, some picture about our Congress, previous Congress. So I think that we must convince world leaders that political action is not negotiable. The true cost of climate change will not be measured in dollars or in euro, but in millions or billions of lives. It is the real human cost of climate change. The clock is ticking. Time is up. It is high time for all of us to act all together, to put into practice the knowledge that science is offering us in order to promote health and dignity for all, in particular for all people. Dr. Tedros Adhanom Ghebreyesus told us that he wrote, I envision a world in which everyone can live healthy. So in this way, we decided to continue our experience with the migration and with the activity in the Mediterranean Sea, as I show in this short clip.
Sono due compassi, uno con un serralino dove si vedono 3 persone e un altro barcone con 250-300 con 250 più altri 250. Noi stiamo dirigendo su un punto dove è prevista la presenza di un barcone con circa 300 migranti a bordo. In ultramare sicuramente GIS e direi una zinga.
Prima direttiva sovrana su ogni cosa la sicurezza, loro e nostra.
Once again, thank you all of you and all of my colleagues working with me and with my staff in Mediterranean Sea, in Ethiopia, in every part of the world. We learn so many things. Once again, thank you very much for your attention.
Thank you. Now, if there are any questions, you can, even online, you can write your questions.
Thank you again for your interesting talks. Are there questions in the room? Yes, Aisha, please.
Thank you. I had a comment and a question. I want to congratulate Esther and the whole GLODERM team on their amazing, amazing work. And I wish there'd been that also when I was a resident. So congratulations. And I promise I'll sign up for the mentor thing. I know you were going to ask me that, so I just made the public announcement. My question was to Andres, how do I say your name? Okay. So snake bites are being reported in Pakistan where the floods are. An epidemiologist working on the ground in the western province, Balochistan. And there's a bunch of venomous snakes, as you might know, in that region. I just wanted to kind of have a question for you. We are very lucky where we have anti-venom, you know, in the West and in certain countries, but a big problem actually is the absence of anti-venom in a lot of the situations. And I had a herpetologist contact me. I don't know if you've noticed that with your work in Sri Lanka.
Yes, I mean, it is a real problem in these times. The antivenom quality had been kept on a high level, on a high standard for a long time, but now the situation has changed as we have low budget products from some areas, overcrowding the market and destroying the economic situation for these companies who guaranteed for a long time this high quality standard. This has created an enormous problem, and this has been realized by the WHO, and they formed a program even to enforce developing high quality standard antivenoms, which would be affordable even for the third world countries. This is ongoing at the moment.
Thank you. Other questions? For GLODERM?
No, so from the people online, they all congratulate for the excellent presentations. And there is a question from Professor Schmidt, but I can't really understand. Can you see the last one? I think there are some typing.
I think the answer is that the question is it's an information point to say that the WHO translates does some translating, offers some translating in terms of leaflets. So that's something that we can think about, but I think we can see that anyway on the WHO website. We're more thinking about simultaneous translation is a conversation that we've been having of live educational material, or maybe dubbing, or maybe subtitles. But thank you for that comment.
I had one comment that I completely forgot to mention, which is not related so much to GLODERM, but to monkeypox, which I know a lot of us are now starting to see in our clinic and increasingly. So along with the International League of Derm Societies and the American Academy of Dermatology, we have expanded the existing COVID-19 dermatology registry, which you may have been familiar with our work over the last 2.5 years, to now have a monkeypox registry. So it's live. We just published a piece about it in the JAD on Monday, so 48 hours ago, and it's reachable at aad.org/monkeypox, and it is not identified cases, so you can still publish case reports, but we would encourage all of you, since I'm suddenly realizing that I should have put a slide about it in my presentation, just to let you know, if you are seeing monkeypox cases, we would encourage you to enter data. We do try our best to do really live data analysis with the goal of just kind of feeding back the information to all of you as quickly as possible. So just a small monkeypox note while I have the mic, which is not so much related to GLODERM, but my other hat as an epidemiologist.
Thank you so much for this information. Any other comments or some words you would like to add? For example, also inspiring words for our incoming next year, for the next meeting. Please feel free to tell us. We are looking forward. Yes? Please.
Yeah, I have a question for Andres. Yeah, do you remember we were together in Sri Lanka a few years back for the tropical dermatology meeting. Recently, I encountered a case of a wasp bite on the cheek, and it has lasted already for 4 years, and she developed subcutaneous atrophy. And I was wondering what toxin or chemical is responsible for the reaction, and whether you have seen similar cases. And in this proportion of cases, are they like jellyfish stings that sometimes after a while the reaction is quiet, and then after some time it develops like recurrent hypersensitivity reaction? And is there an anti-venom for this venomous type of like bites and stings?
Both things are still unsolved questions, unfortunately. Research is going on in these fields, but the question has been answered yet. I have never experienced myself an atrophy, but more granulomas or dermal fibromas or something like that. So I could not even share this experience, but with jellyfish stings, it's a well-known effect that you have long-lasting trouble, long-lasting skin or peripheral nerval disturbances. There is no venom had been named being responsible for that so far. We just see from time to time the effect. We have even the idea, if you have an incidence of a contact with nettling tentacles, and it heals and it rises again after 14 days or 3 weeks. This is most likely an allergy, but even the background, the immunological background of this has been solved yet. Research is going on in this field.
Thank you. Another question online.
Question here. Someone is asking if they can have the recording of the presentations, but I'm not aware of this. I don't think.
They just have to write an email. We will see it in the closing remarks.
Okay, so maybe
we can
yes,
answer
okay.
it. So I think because of time,
yeah,
it's time for say thank you again to you for your very good presentation and for your support in the name of our task force, and from the albinism project. And wine is, we should have some it from Austria, especially produced for that. And for Andreas, the same. Thank you. Thank you. Thank you.
okay, thank you again. Thank you all the speakers from the outstanding presentations. Again, thank GLODERM for making this possible, this meeting. And also we have to give a special thanks to Ursula. Now, I don't know, we have to call her. Ursula is the leader of organization. And also Hannes, who is in the back of the room. Thank you. Our technical support. And also Roberta, who is not here, she helped us from the hotel side. Thank you all for paying attention and for your participation to our meeting. Thank you for your discussions and your participation. Of course, you are welcome to write us if you have any ideas, any input, if you want to share your experience. So we are happy to receive your emails and I mean, whatever you like. Thank you again. Also, we wish you a nice evening and a nice Congress in Milan.